Science in a Sec, Parkinson's disease and you. SwallowSafe.com/education is an ASHA-approved CEU provider, and we have courses that cover a wide range of topics. These courses are available to anyone, but also provide clinicians with the continuing education credits they need for relicensure. We get questions about some of the terms and topics in those courses, so at Science in a Sec, we're here to give you a little more information. Today, I'm going to give you an overview of key concepts in Parkinson's disease, signs, symptoms, and how it can relate to your life. Imagine your brain is a high-speed command center that sends go signals to your muscles using a chemical messenger called dopamine. To move slowly, you need a steady supply of it. In Parkinson's, the power plant that makes this dopamine, a tiny area deep in the brain called the substantia nigra, starts to wear out. As dopamine levels drop, your brain's internal wiring begins to fail. The clear signals that used to create fluid movement become faint or garbled, making it feel like your body is trying to move through thick molasses. Living with the disease is a mix of visible and hidden struggles. On the outside, you might see a rhythmic tremor when a person is resting, a frustrating muscle stiffness, or a general slowness that makes buttoning a shirt feel like a marathon. On the inside, the hidden symptoms like acting out vivid dreams, mood changes, or constipation often appear first. Because every brain is different, the disease follows its own clock. Some people have a mild version that stays manageable with medicine for decades, while others may face challenges with memory and balance much sooner. Your central nervous system handles everything from breathing to grabbing a cup of coffee without you ever having to think about a single muscle twitch. This center relies on three main players: the brainstem, the substantia nigra, and that chemical we talked about, dopamine. Check out our other Science in a Sec articles to learn more. Parkinson's occurs when this system begins to fail. The brain slowly loses the specific nerve cells responsible for producing dopamine. Without enough dopamine, the gears of movement get stuck. This leads to bradykinesia, which is the clinical term for moving in slow motion. Because the volume knob is turned down, signals become muffled, causing muscles to feel rigid and stiff, or leading to a resting tremor, that telltale shaking when a hand is at ease. This condition currently affects about 1 in every 100 people over the age of 60, though it presents differently for everyone. For some, it is a mild, slow-moving journey that stays manageable for decades. For others, it may follow a more aggressive form where the loss of these cells happens faster and begins to impact memory and even autonomic function like blood pressure early on. Essentially, when the substantia nigra can no longer supply the dopamine oil, the brainstem highway struggles to deliver the clear, smooth instructions your body needs to move efficiently. Parkinson's is currently the fastest growing brain disorder on the planet, and the numbers are climbing quicker than anyone expected. Globally, about 12 million people are living with the condition today, a number that has more than doubled since the 90s and is on track to hit 14 million by 2040. This pandemic is being fueled by a mix of people living longer and increased exposure to industrial chemicals and pesticides, especially in rapidly growing areas like China and Latin America. Right here in the United States, the situation is hitting a new peak. Roughly 1.2 million Americans are living with PD right now, with nearly 90,000 new people diagnosed every single year. That is a massive 50% jump over what experts used to see. While the risk goes up significantly once you hit 65, men are about 1.5 times more likely to get it than women. This isn't just a health crisis, it's a massive economic one. By 2024, the cost of Parkinson's in the U.S. reached a staggering $82 billion a year when you factor in medical bills, lost wages, and the grueling work of unpaid family caregivers. This is a level of financial strain we didn't expect to see for another decade, proving that Parkinson's is moving faster than our current systems were prepared for. Parkinson's begins well before symptoms are noticeable. Long before the first tremor appears, Parkinson's sends quiet distress signals known as prodromal signs. According to the Brack hypothesis, the disease doesn't start in the brain's movement centers, but in the medulla and olfactory bulb. This explains why a fading sense of smell, or hyposmia, is often the very first red flag, affecting nearly everyone years before a formal diagnosis. Another major warning sign occurs during sleep. In a healthy REM cycle, your brain acts as a safety switch, paralyzing your muscles so you don't act out your dreams. In REM sleep behavior disorder, this switch breaks. Because the disease physically damages the brainstem, the area responsible for this paralysis, years before it hits the movement centers, people may kick, punch, or yell in their sleep for over a decade. Since more than 90% of people with RBD eventually develop a neurodegenerative condition, it is a powerful predictor for doctors. This sleep-first version of the disease often points to a subtype which can progress faster and involve the autonomic nervous system. This leads to autonomic dysfunction, such as chronic constipation or orthostatic hypotension, a sudden drop in blood pressure that causes dizziness when standing. While these signs like anxiety, fatigue, or sleep issues could be caused by many things, when they cluster together, they create a roadmap. Scientists track the buildup of the protein alpha-synuclein during this phase, hoping to intervene before the famous motor symptoms even take hold. Early detection through these red flags gives families a massive head start in managing the journey ahead. Dysphagia is another early sign of Parkinson's. While we usually associate Parkinson's with tremors, a hidden danger often lurks in the throat, dysphagia, or swallowing dysfunction. It's not just an annoyance. It's a breakdown of the brainstem's metronome that coordinates the 50 or more muscles needed to eat safely. In Parkinson's, the same protein clumps that cause shaky hands also make throat muscles rigid and slow. This breakdown happens in 3 acts. First, the tongue struggles to pump food backward. Next, the swallow reflex delays, allowing food to slip into the airway, a terrifying silent aspiration where food enters the lungs without triggering a cough. Finally, the esophagus loses its rhythmic squeeze, making food feel permanently stuck. This is a matter of survival. Aspiration pneumonia is the leading cause of death in Parkinson's. Key red flags to watch out for. First, physical clues. Frequent drooling, a wet or gurgly voice after drinking, or meals taking much longer to finish. 2. Weight loss. Unintentional weight loss is a major signal that eating has become unsafe. 3. The silent risk. A weakened cough reflex means the body can no longer clear the pipes, leaving the lungs vulnerable to infection. The stats are startling. While only a third of patients report trouble, medical tests show that up to 82% actually have swallowing dysfunction. What speech pathologists look for in Parkinson's-related dysphagia. When we age, our bodies naturally slow down, and that includes the way we swallow, a process doctors call presbyphagia. However, specialists have to be careful not to confuse these normal, healthy changes with something more serious like silent aspiration. Unlike a typical wrong pipe moment where you gasp, cough, or choke, silent aspiration happens without any outward warning signs. To tell the two apart, experts can't just watch a patient eat. They have to look inside the body using gold standard imaging tools. One common method is the video fluoroscopic swallowing study, which is essentially a real-time X-ray movie of a person swallowing. This allows specialists to see when food or liquid slips past the vocal folds and into the airway. Another tool is the fiber optic endoscopic evaluation of swallowing, where a tiny camera is passed through the nose to get a bird's eye view of the throat. During these tests, doctors or speech-language pathologists evaluate the swallow, emphasizing the risk for aspiration, whether silent or not. If the material passes below the vocal folds and the patient doesn't even flinch or try to cough it out, it is officially graded as silent aspiration. Because a patient's voluntary cough might seem fine, even when their reflexes are failing, specialists sometimes use a reflexive cough test to see if the body still shows how to protect itself automatically. They also look for signs that might signal a hidden problem, such as persistent drooling, a gurgly or wet-sounding voice after drinking, or that significant weight loss. While normal aging might make us swallow a little slower or less efficient, it shouldn't result in food entering the lungs without a fight. If the body stops reacting to these errors, it marks the shift from a normal aging throat to a clinical condition that needs immediate attention. Parkinson's patients with dysphagia are at a high risk of hospitalization. When a person in the early stages of Parkinson's disease is hospitalized for a respiratory incident, like a bad bout of bronchitis or the flu, the situation is often far more critical than it appears on the surface. Even if their tremors are mild, dysphagia fundamentally changes their risk profile. Because the disease numbs the throat sensors, there is no outward sign of distress when dysphagia occurs, allowing the lungs to become dangerously infected before the medical team even realizes aspiration occurred. This often triggers a vicious cycle. The initial respiratory illness weakens the muscles used for breathing and swallowing, which leads to more aspiration, further drowning the lungs in bacteria and fluid. The leading cause of death in Parkinson's is aspiration pneumonia, a severe lung infection that occurs when food, liquid, or even simple saliva enters the lungs instead of the stomach. The hospital environment itself introduces secondary risks that can be fatal. If a patient is placed on NPO status, that is medical shorthand for nothing by mouth, during a crisis, they may miss critical doses of their PD medication. Missing even a small window of levodopa can cause the throat muscles to become rigid or paralyzed, a state known as an off period, making aspiration almost a certainty if they later try to swallow pills or water. Furthermore, many patients suffer from a weak voluntary cough, meaning they lack the explosive power needed to clear the inflammatory fluid from their lungs, leading to rapid respiratory failure. There is a dangerous early stage paradox at play here. Because these patients often look too healthy to have severe trouble, staff may miss the fact that up to 82% of people with Parkinson's actually have some form of swallowing dysfunction. This makes the first 48 to 72 hours of hospitalization a critical window. Without an early instrumental exam by an SLP, such as FEES, using that tiny camera, or VFSS, that swallow x-ray, the risk of a fatal event skyrockets. Ultimately, the danger isn't just the breathing problem that brought them to the ER, it is the hidden swallowing failure that prevents them from ever leaving. Catching aspiration early is the only way to protect the lungs and ensure a safe recovery. Immediate safety techniques speech-language pathologists suggest. Think of compensatory strategies as swallowing hacks. You can change your body's alignment to guide food safely towards your stomach and away from your airway. For instance, the position of your head or tucking your chin towards your chest narrows the opening to your windpipe, acting as a shield. You can also use gravity to your advantage by leaning forward slightly or turning your head to one side to steer food down your strongest path. While these moves are staples in rehabilitation, their mission changes depending on the patient. For some recovering from a stroke, the chin tuck is a temporary bridge. Because a stroke is a one-time brain injury, the swallowing reflex may wake up and recover within weeks. For those living with Parkinson's, the story is much more complex. Because Parkinson's is a progressive neurodegenerative condition, the muscles don't just recover. They face increasing stiffness and slowness. This makes holding specific poses physically exhausting, and their effectiveness can fluctuate wildly based on whether a patient is in an on or off medication cycle. Because of this, specialists are moving away from quick fix postures for Parkinson's and towards active gym workouts for the throat. One of the most effective tools is respiratory muscle strength training. This involves using a pressure device you blow into to strengthen the muscles used for breathing and coughing. By increasing your expiratory pressure, you make your internal alarm system more powerful, ensuring you can forcefully cough out anything that accidentally slips towards your lungs. Even voice therapies that focus on speaking loud help by forcing the tongue and throat to work harder, which naturally carries over into a safer swallow. The final, and perhaps most overlooked part of this safety plan is oral hygiene. In Parkinson's, the greatest risk isn't just the food you eat, it's the bacteria in your mouth. If you accidentally breathe in a tiny bit of saliva, the risk of developing pneumonia is significantly lower if your mouth is free of harmful bacteria. Brushing twice a day and maintaining a clean oral environment is just as much a swallow strategy as any specialized exercise. By combining these daily habits with targeted muscle training, you ensure the engine of your throat stays strong enough to protect your lungs for the long haul. A common overlooked safety technique: create a calm environment. For people living with Parkinson's, eating is much more than a simple reflex. It is a high-level coordination task that requires the brain's full attention. Because the disease can affect both physical movement and the ability to focus, The safest way to enjoy a meal is to treat it as the only activity happening at the moment. When someone tries to talk, watch television, or manage a busy environment while eating, their brain has to split its processing power, which often leads to the swallow becoming uncoordinated. Creating a calm, quiet space is a foundational part of therapy because it allows the person to stay mindful of every bite. This focus is especially important for managing impulsivity, as cognitive changes can sometimes cause a person to eat too quickly or take bites that are too large without realizing it. By removing background noise and interruptions, the person can better monitor their own pacing and physical control. Even during medical checkups, clinicians have found that a distracted patient might perform poorly, not because they lack the physical ability to swallow, but simply because their attention was pulled elsewhere. Ultimately, a peaceful environment acts as a safety net, ensuring that the complex sensory signals needed for a safe swallow remain sharp and effective. We talk about the importance of a calm environment, give some tips and more information on our swallowsafe.com website and in our Swallow Safe podcast series. Find out more about how you can connect with the broader community and find dysphagia-friendly recipes anyone can enjoy. Having this type of peaceful, dysphagia-friendly connection can be so helpful to the Parkinson's patient who may be experiencing some cognitive issues associated with the disease's progression. Let's take a look at some of those issues in the next section. Understanding how mild cognitive impairment or dementia affect swallowing in Parkinson's. In Parkinson's, the brain and the body have to work in perfect harmony to handle something as simple as the swallow. When cognitive decline enters the picture, the harmony falls apart, making it the single biggest warning sign that a patient might develop aspiration pneumonia. This happens because the brain acts as the air traffic controller for the throat. Once dementia or confusion sets in, the controller can no longer manage the complex timing needed to keep food out of the lungs. In fact, most Parkinson's patients who end up in the emergency room with lung infections are also struggling with memory loss or sudden bouts of confusion, proving that the mind's health is directly tied to how safely a person can eat. The risk increases because cognitive decline changes how a person behaves at the dinner table. A patient might become impulsive, taking bites that are too large or eating much faster than their throat can handle. Because their focus is split, they can no longer dual task the complicated physical sequence of a safe swallow while doing things like talking or watching television. To make matters worse, many patients lose the self-awareness to realize they are choking or struggling, so they don't think to use safety techniques they have learned. Even the environment and medical treatments play a role in this dangerous cycle. Certain medications used to treat Parkinson's can actually cloud the mind further or cause sleepiness, which makes a person even less likely to swallow correctly. Because cognitive impairment is such a strong predictor of life-threatening lung complications, doctors can't just look at the throat muscles when assessing the patient. They have to look at the whole person, ensuring that any plan to prevent pneumonia accounts for the patient's mental clarity and ability to stay focused during a meal. Early mild cognitive impairment and dementia symptoms in Parkinson's. When we talk about Parkinson's, we often focus on the physical shakes or stiffness, but for many patients and caregivers, the changes in thinking and memory, what clinicians call cognitive changes, are just as impactful. It's helpful to think of the brain as a complex computer where the processor is slowing down, making it harder to toggle between tasks or find the right words. For many, this journey begins with mild cognitive impairment. This isn't just dementia. Rather, it's a noticeable glitch in thinking that doesn't yet stop someone from living their daily life. About 20 to 25% of people already have these subtle changes at the time they are first diagnosed with Parkinson's. It usually shows up as executive dysfunction, which is a fancy way of saying the brain's manager is struggling to plan, organize, or multitask. You might also notice bradyphrenia, which is simply slowed thinking. Just as the legs move more slowly, the mind takes a bit longer to process a question or make a decision. As the disease progresses, the risk for more significant changes increases. Parkinson's dementia occurs when these thinking problems become severe enough to interfere with independent living, like managing finances or driving. Statistics show that while not everyone will develop dementia, about 50 to 80% of people living with Parkinson's may face some kind of cognitive impairment. A key sign that distinguishes Parkinson's from other types of memory loss is the presence of visual hallucinations, seeing things that aren't there, and significant fluctuations in alertness, where a person might be sharp 1 hour and very confused the next. Scientifically, these changes happen because the brain is dealing with more than just a lack of dopamine. It's also struggling with a protein called alpha-synuclein, which clumps together into Lewy bodies. These clumps disrupt the parts of the brain responsible for memory and mood. This is why many patients also experience apathy, a loss of get up and go, or anxiety, which are actually chemical symptoms of the disease rather than just a reaction to the diagnosis. The good news for caregivers is that early detection of these non-motor symptoms allows for better planning. We now know that the Parkinson's pandemic isn't just about movement, it's about a total brain health shift. By recognizing neuropsychiatric symptoms like depression or sleep issues early on, families can work with doctors to adjust medications and use cognitive exercises to keep the processor running as smoothly as possible for as long as possible. Medication treatments and physical therapy for Parkinson's. When it comes to treating Parkinson's, think of the goal not as a cure, but as sophisticated symptom management. We are essentially trying to supply the brain with the chemical oil it can no longer produce enough of: dopamine. Without sufficient dopamine, the body's movements get stuck or shaky. Medication is the primary tool used to unstick them. Dopamine and other neurotransmitters are covered in our Science and Sex series, What is a Neurotransmitter? We recommend checking that out because it's really helpful to understand what's going on in Parkinson's. Managing PD is a sophisticated balancing act that aims to refill the brain's dwindling supply of dopamine. The gold standard treatment is levodopa, a raw material that converts into usable dopamine once it reaches the brain. It almost always pairs with carbidopa, a protector that prevents the medicine from breaking down in the bloodstream, which helps avoid severe nausea. While highly effective at smoothing out stiffness, long-term use can lead to dyskinesia, which are jerky, involuntary movements, or off periods where the medication wears off too soon. To delay these complications, doctors may use dopamine agonists like pramipexole, which acts to trick brain receptors into activating. They may also use extender drugs, COMT or MAO inhibitors, which essentially jam the garbage disposal by blocking the enzymes that naturally break down dopamine. This keeps the chemical oil in the system longer, reducing the time when symptoms resurface. When pills aren't enough to steady tumors, advanced options like deep brain stimulation act as a biological pacemaker for the brain. Because Parkinson's is a full body experience, care goes beyond movement. Hidden symptoms like depression, memory fog, or visual hallucinations are managed with targeted neuropsychiatric medications. Treating these non-motor issues is just as critical as fixing the shakes, as it recalibrates the brain's internal sensors to maintain a high quality of life. The goal of the entire pharmacological puzzle is to keep the gears of both the mind and body running as predictably as possible. Beyond pills, movement itself is the medicine. Regular physical therapy, whether through traditional exercise, pool workouts, or even virtual reality, is vital for staying mobile. Currently, the most effective prescription is hitting the gym or clinic 2 to 3 times a week. While we haven't found a way to stop the disease entirely, combining a precision medication cocktail with rigorous exercise and, in some cases, surgery allows patients to keep their independence for much longer. One of the most frustrating things about Parkinson's is freezing of gait, where your feet feel suddenly glued to the floor despite your intention to walk. Since standard medications don't always fix this short circuit, we use clever sensory triggers to retrain the brain. Action observation therapy uses mental priming by having patients watch videos of smooth walking, while Nordic walking uses trekking poles to create a rhythmic momentum that overrides the freeze. For a more social reset, Irish set dancing has proven remarkably effective because its complex footwork and musical rhythms force the brain to bypass stuck pathways. While general pool exercises are great for balance, they don't specifically target freezing episodes as well as these land-based, goal-oriented therapies. Ultimately, when the dispatch center fails to send a clear signal, these specialized movements teach the brain an entirely new way to walk. Make sure to coordinate with your care team for help. Managing Parkinson's effectively is rarely a solo act. It requires a collaborative care model. Because the disease affects everything from the power plant of the brain to the highway of the brainstem, a patient's clinical team must evolve into an interdisciplinary circle of specialists to address both motor and non-motor symptoms. At the center of this team are the core specialists who serve as the anchors for long-term care. The quarterback is typically a movement disorder specialist, a neurologist with advanced subspecialty training specifically for Parkinson's. They manage complex medication regimens such as fine-tuning carbidopa-levodopa levels and evaluate patients for advanced surgical interventions like deep brain stimulation. Supporting them are physician's assistants and nurse practitioners who provide the boots-on-the-ground education and frequent adjustments needed to manage daily symptom fluctuations. To keep the body moving, a physical therapist focuses on gait, those walking mechanics, and balance, using big movement exercises to keep the brainstem's signals to the limbs as clear as possible, ultimately reducing the risk of life-threatening falls. As the journey continues, The quality of life team steps in to manage the often hidden symptoms that impact daily independence. An SLP is critical for managing dysphagia and communication. They use instrumentation tools like FEES to catch silent threats to the lungs. While the PT focuses on walking, the occupational therapist focuses on doing, helping with fine motor skills like buttoning shirts or adapting the home for safety. To monitor the brain's processor, a neuropsychologist assesses for MCI or dementia, while social workers help families navigate the complex logistics of insurance and long-term planning. The extended support circle includes gastroenterologists for chronic constipation, urologists for bladder urgency, and mental health counselors to support the emotional marathon of the diagnosis. However, the most vital member of this team isn't a clinician at all. It's the caregiver. As the primary observer, the caregiver provides the real-world data on when medication wears off or when a swallow seems slightly different, allowing the medical team to make the precise adjustments necessary for a high quality of life. If you are a caregiver or clinician, check out our educational courses for more detailed information. The journey through Parkinson's is often described as a marathon, but today, that marathon is being run on a path lit by more scientific innovation than ever before. While we have spent decades learning how to manage symptoms, we're now entering a golden age of research where the goal has shifted from simply living with the disease to fundamentally stopping it in its tracks. We are seeing the rise of neuroprotective treatments and gene therapies. Also, the development of biomarkers means we're becoming able to detect the very first quiet distress signals of the disease years earlier, allowing doctors to intervene before a single tremor even begins. For caregivers, hope is found in the power of the interdisciplinary care team. We are no longer guessing in the dark. With tools like FEES and the specialized big movement protocols of physical therapy, we have a roadmap to keep loved ones safe, vocal, and mobile for much longer than was possible just a decade ago. Every day, the gap between diagnosis and disability is widening by sophisticated pharmacological puzzles. The future of Parkinson's is not a story of inevitable decline, but a story of resilience and neuroplasticity. The brain is remarkably adaptable, and with the collaborative care model, patients are not just surviving, they are thriving. We are moving towards a world where Parkinson's is manageable rather than a life-defining condition. For every patient and caregiver, the message from the scientific community is clear. Research is accelerating. Detection is sharpening. And the finish line, a way to slow or stop or cure this disease, is closer than it ever has been. Thank you for spending this time with me today. If you are a clinician and are looking for CEUs, we have neurology and other courses on swallowsafe.com/education. Subscribe to our Substack for more podcasts, articles, and science in a sec. And don't forget to follow us on all your favorite social media platforms. Click on any of the links on our Substack to be automatically directed to our social media pages.